Hey guys, this is Melissa Peters. I'm an occupational therapist and a professor at Baker College in Allen Park. In a previous video, we broke down the dreaded brachial plexus and how to draw it, what all the nerves are, what they innervate, and just kind of put that piece together. In this lecture, we're actually going to talk about the four main branches of the brachial plexus and what it does in the arm and how it innervates the arm and the hand. Again, as practitioners, we need to understand what's being innervated, what's our sensation distribution, so that we start to know what's going wrong and what would be appropriate therapeutic activities that we could start using for these patients. Okay? Let's go back for a second and think about the hand. All right? The hand has a lot of really important functions. First of which, the hand gives us prehension. When we think about it, we have three different types of pinches. We have our pincer pinch, all right, which is the most for fine coordination. We use this pinch when we're picking up small objects, picking up coins, buttoning a shirt. We use this pincher, all right, type of a motion. Then we have kind of our palmar prehension, also known as our three-jawed chuck, where you're using the pad of the thumb, but you're also using the pad of the index finger and the middle finger. We start to use this again for motor coordination, fine motor coordination. It's also a very big precursor to handwriting skills. So with our kids, we really want to make sure that we're working on this motion so that they can be ready to start doing handwriting activities. It's usually how we do hold a pen or a pencil. Very important skill. Then the strongest of those three pinches is what's known as our lateral pinch or key. This is where the pad of the thumb is actually coming into contact with that medial aspect of that index finger's PIP joint. Okay, this is the strongest of the three, and what we'll learn as this goes on is we would really need that ulnar nerve to allow for us to have this powerful pinch. It is absolutely the strongest of the three, but has less coordination benefits. But we need to know, if we're thinking about just even pinch prehension, what nerves are being innervated, what muscles do I need so that I can pick activities to strengthen the specific functions. Okay? We also in the hand have things known as our in-hand manipulation skills. Okay? An example of in-hand manipulation skills would be our ability to translate items from the palm of our hand out to the pads of the fingers. All right? Or can you take something that you pick up from the tips of your fingers and translate it into the palm of your hand? A good example of this would be putting coins in a vending machine. Can you pick up the coin and then translate it to the fingertips and then ultimately put in your money? Pretty good example of translation. All right. We also have something known as shifting, which is when you're manipulating objects within the pads of your fingers. So a good example is if I'm going to move up and down of this marker, I'm actually shifting because I'm using the pads of my fingers. Not translation, because again, translation would be going from the palm to my fingers. So that's what I would use to prepare for handwriting. But shifting would be manipulating the object up and down using the pads of my fingers. Okay. We finally have rotation. This is what that means. Rotation, our ability to rotate an object using our hands. Okay. So those are our in-hand manipulation skills that we need. We also have grasp, okay? So an example of that would be cylindrical grasp, my ability to pick up an object such as this, all right? A water bottle, a glass of water, all right? We need innervation from the median and ulnar nerves, especially in order to have this grasp. And what we'll learn is we really need that ulnar nerve for power grasp because it's going to allow us to grasp with those bottom two fingers and give us that ulnar deviation so we can have power grasp. You're going to see a theme here with that ulnar nerve and powerful things. Power pinches, power grasps. We also have a cylindrical grasp, which is when we would grab like a ball-shaped item, rotate a dial, all right, spinning a light bulb. That would be more of a cylindrical type of a grasp. So those are some of the functions of the hand when we think of physically what we do. But the other thing our hand does, if you think about it, it helps us to communicate. We communicate with body gestures. We communicate with movements. We communicate with our hands. We also communicate through touch. We touch people. We shake their hand. We hug people. So when we're talking about hand injuries, it's not just about the function. It really affects people on a psychological level just as much as it does on a physical level. So we need to really think about that, the hand and all of its functions. So we need to really respect the hand and understand that a lot goes into this. And really, this takes us back to understanding kind of how that brachial plexus flows and gives us our four main nerves, which go through the arm and the hand, which are our musculocutaneous nerve, okay, our median nerve, our radial nerve, and our ulnar nerve. Those are the four main branches that come off of the brachial plexus. Again, I did this in a previous video where we just talked about getting to that point, all right, but now we're talking about how they flow. I find the easiest way to understand them, learn your muscles, learn your anatomy, is to kind of just follow the nerve as it flows and understand what it does as it goes down. If you do that, you will know the muscles it innervates, the actions that happen, what's happening in those joints, what kind of sensation distribution it has. So when you're given a question in a course, all right, your MVCOT exam, you're out in the clinic working with a patient, if you can think through the process logically, it'll stick and you'll be able to come up with an answer that makes sense. But again, if you're always just trying to memorize without putting it all together, it can be harder to learn how to have good clinical reasoning. So hopefully by the end of this, you'll kind of understand the flow in a way that lets you kind of have that edge, that clinical reasoning edge, which is our goal. So I like to take dry concepts like this and try to make it a little easier to understand and hopefully a little fun in the process. We'll see. Let's start. All right, we know that the brachial plexus starts, all right, those spinal nerves are coming off the cervical spine. It all starts up in the neck, all right? Then the brachial plexus continues through the axilla, which is the armpit, and then ultimately it's going to start its main branches down through the arm. The first one we're going to talk about is musculocutaneous nerve. In some ways, the easiest one to remember because it doesn't do a whole lot. So let's start with musculocutaneous nerve. Check it off our list. Musculocutaneous nerve. All right, once it comes through the axilla armpit, it comes right on the front, the anterior part of the arm. First muscle it bings, bing, coracobrachialis. It's that little muscle that helps us with shoulder flexion. Small muscle, but it helps us with shoulder flexion, and it gets innervated by musculocutaneous nerve, coracobrachialis muscle. Okay? It continues down. All right, the big muscle here, what is the big muscle on the anterior part of the arm? It's our biceps brachii. All right, biceps brachii is innervated by musculocutaneous nerve. What do the biceps do? They give us elbow flexion. Okay, elbow flexion comes in from musculocutaneous nerve. It is also our main supinator. All right, so not only does it allow for flexion, it gives us supination of the arm. All right, powerful muscle, obviously needed to perform most ADLs, most functions. All right, so that's important. The only other muscle that musculocutaneous nerve innervates is the brachialis muscle, which is just deep. All right, it's beneath or behind your biceps brachii. And it allows for elbow flexion, but it allows for elbow flexion when your arm is in a neutral position, in this position. Remember, biceps brachii, my palm is supinated if I'm using my biceps brachii. I'm using my brachialis muscle if my forearm is in neutral. So think karate chop. All right, that would be your brachialis muscle. That's your musculocutaneous nerve. And that's, in fact, what it innervates. So now if we think clinically, if you had damage to your musculocutaneous nerve, what would you have a hard time doing? Well, shoulder flexion would be slightly impaired because of that coracobrachialis, but it's a small muscle. It's not the prime mover. So you'd still have shoulder flexion, but it might be weaker. But elbow flexion would definitely be the impairment of that musculocutaneous nerve. And again, especially if that palm is supinated or if it's in neutral position. All right, that's our musculocutaneous nerve. All right, now we will move on to the radial nerve coming off that brachial plexus, that posterior cord of the brachial plexus. Now, the radial nerve is hanging the most posterior as it comes out of that armpit. That's important to know because when you think about things that can go wrong, because of its location, it's vulnerable to certain things. We'll talk about Saturday night palsy in just a minute. But that radial nerve travels down to the armpit and it travels through the posterior aspect of the forearm. Okay? And again, what is the muscle that is right here in the posterior compartment of the forearm? Triceps. Our tricep muscles, which allow us for elbow extension. Here we go. All things that are extension, here comes the radial nerve. It is our extender, all right? So it allows for elbow extension. It continues. Radial nerve continues to travel, and it goes through the elbow, okay? And once it gets into the forearm, I want you to think party on, like fireworks, hand slaps, butt slaps, hug it out, like radial nerve is in the building because the radial nerve does absolutely everything in the posterior area of the forearm. It does it all. So that makes it kind of easy. So for example, you've got your anconeus muscle that also helps with elbow extension, radial nerve. All right. Now we start running through all those bigger muscles within the forearm. Brachioradialis. Brachioradialis allows for elbow flexion when the palm is pronated. It's the only guy the radial nerve does that is not really extension. Brachioradialis allows for elbow flexion when the palm is pronated. Everything else, extension. It allows your wrist to extend via extensor carpi radialis and extensor carpi radialis brevis. It allows for wrist extension, okay? Or we can go this way, wrist extension. It also innervates extensor carpi ulnaris. So don't confuse that with the ulnar nerve. Again, extension is all things radial nerve. So any wrist extender is coming in from your radial nerve. So that's extensor carpi radialis longus and brevis and extensor carpi ulnaris. Okay? Now we start to get into what's known as the extrinsic muscles. They are called extrinsic muscles because they are located in the forearm, but they operate on the hand because of their tendons that reach all the way down to those fingers. So we're still talking extension, but it also has extrinsic muscles located in the forearm, okay, but operate on the hands. All right, our middle three fingers get extension from extensor digitorum. Okay, again, extrinsic, located in the forearm, extensor digitorum. Little finger gets its own muscle, extensor digiti minimi. Extensor digiti minimi gives that little finger its extension. The index finger is a pretty important finger. It does a lot of functions, so it gets a little help from another muscle. So you get the extensor digitorum support, but it also gets extensor from a muscle called extensor indicis, which is giving that index finger extension as well. Okay, so you've got extensor digitorum, giving those three fingers its extension, extensor digiti minimi, and extensor indicis, all right, giving the fingers our extension, again, via those tendons that are coming down to allow for that. Let's not freak out about the thumb. Everybody freaks out about the thumb. The thumb is easy, and it can be easy, right? We have extensor pollicis longus, which is giving us our IP extension of the thumb. Extensor pollicis longus. If there's an extensor pollicis longus, we have an extensor pollicis brevis, which is giving us thumb extension. Thumb extension. You want to understand the motion of thumb extension, you can do a thumbs up sign. That is thumb extension. Notice extensor pollicis longus is extended and extensor pollicis brevis extended. You can also do bang bang. All right, shoot that gun. That would also be extensor pollicis longus and extensor pollicis brevis. Abduction of the thumb confuses people because some people refer to it a couple different ways. If you want to do thumb or palmar abduction, you make a C. Okay? Now we have abductor pollicis longus. Abductor pollicis longus is giving us our thumb abduction, thumb abduction. Okay? This is also referred to as palmar abduction. The thumb is coming away from the hand. Palmar abduction. Abductor pollicis longus. That's everything as far as what is giving our hand, all right, its function. It's all extension. The only one that was an extension, remember, was that brachioradialis, all right, that gave us our elbow flexion when the palm was pronated. Everything else is wrist extension, finger extension. And you've either got the extrinsic muscles operating, or in this case, you don't have any intrinsic muscles. Intrinsic muscles are the ones located in the hand itself. Notice for this extension, we didn't have any of that. It was all extrinsic. They were all in the forearm operating on the fingers and thumb. Let's talk sensation. When we're talking about sensation, we've got the volar surface of the hand, the front, palmar surface, or the dorsum of the hand, all right, the back. Makes sense. Now, do you think radial nerve does a lot on the volar surface, palmar surface? No, it didn't do anything here. Not a thing. Flip your hand over, radial nerve dominates in this area. Obviously, it's going to do thumb. You're going to have sensation through the thumb. All right? The majority of the dorsum of the hand, radial nerve. And then it comes up through this finger, and this finger. All right? The only thing that's a little different is it doesn't do the fingertips. That's actually going to be your median nerve. Again, sometimes anatomy likes to throw us a curveball, but no problem. We got this. All right? Everything else is radial nerve. All right? Think about all this is radial. The only thing that's not is this. Okay? And it makes sense because you're thinking about what it does. It should innervate that skin that's, with regards to it. So if you understand the muscles that it innervates and the movements, you should pretty much have a good handle on the skin that innervates. But we need to know this because when we're getting out our 2-point discriminators or our monofilaments and doing our sensory testing, you need to know what you're innervating, what nerves are being innervated. All right, so you can start to figure out what nerve might be damaged. Maybe I want to specifically test within that region. Or maybe I'm doing random checks and I'm noticing a trend in that radial nerve distribution or in that median nerve distribution. So we want to be thinking about that. So again, radial nerve, again, dominates the posterior aspect of the arm. It's working in extension. Works in extension. So things that can go wrong, all right? These are the things that we can have happen within that radial nerve. First one, Saturday night palsy, all right? Saturday night palsy is when you've got compression in that axilla, and because of its location, you can start having pain, numbness, tingling, lack of function within that radial nerve. A good example would be if you had crutches fit improperly, someone was just hanging down on those crutches, causing that compression, you're going to have that radial night palsy, all right, or that Saturday night palsy, also known as radial nerve palsy. All right, so that's one thing that can happen within the radial nerve. Because of its location back here in the arm, if you had a humeral fracture to the body of the humerus, you could have radial nerve damage because it runs along with the humerus in that posterior area of the arm. So you fracture that humerus, you could have a problem with the radial nerve. Okay? Now, you can have something known as lateral epicondylitis. Now we start to have inflammation of the tendons of the wrist extensors. And those wrist extensors, and you should feel it even on your own hand. When you start extending your wrist, it's the lateral side that's getting irritated. That's the lateral epicondylitis due to overuse of that wrist extension motion. So they call this tennis elbow. And it makes sense because you think about swinging your tennis racket, right? It's going into wrist extension, a lot of it. Okay, so that's kind of how you can remember that lateral epicondylitis. All right, so that's another thing you can have. Another very common injury to the radial nerve is known as de-Quervain's. De-Quervain's, where you have a repetitive strain injury due to potential overuse, and what it's affecting is extensor pollicis brevis, not longus, because it's not this motion that's starting to wear out. It's extension from here, more the base of the thumb. So you have your extensor pollicis brevis is being overused, and your abductor pollicis. So they call this new mommy syndrome because you think about when you're going to pick up those babies all day long, you're abducting and extending the thumb and putting a lot of pressure on the thumb. Okay, and again, it's repetitive strain type of injury. The way you test for this is called Finkelstein's test. All right, you have somebody take their thumb into flexion as such, wrap your fingers around. What you're going to do is you're going to just give that ulnar deviation. You're going to have them push down. And if they have de Quervain's, they're going to have a lot of pain and discomfort within those tendons. It's going to be very uncomfortable. That is your Finkelstein's test, which would tell you that you have a problem with de Quervain's that you can then link back to a radial nerve issue. Okay? That's how that works, right? The clinical sign we see with radial nerve injuries is wrist drop. Because, again, the radial nerve gives us all things that are extension. If you see people that kind of have that wrist drop phenomenon, you know that we have a radial nerve injury. Sometimes that's when you start to see things like those dynamic wrist extension splints, dynamic extension splints. Okay, that's again due to radial nerve problems that we might start to see. Okay, so let us move on. We've nailed 2. Musculocutaneous nerve, done, no problem. Radial nerve, done, no problem. All things posterior in the arm, all things extension, got it. Now, we move to the median nerve. Let's do it. Median nerve, again, everything goes through the armpit or the axilla, and now they start traveling through the arm. The median nerve travels on the medial aspect of the arm. It travels on the medial aspect of the arm. Just know it's going to actually be hanging out with that ulnar nerve. They both go down there together. But it doesn't do anything yet. It just travels down the medial aspect of the arm, and it crosses anteriorly in that cubital fossa. Crosses anteriorly. Now, the median nerve, once it hits the forearm, party on. I mean, high fives, butt slaps, hug it out, like median nerve is in the house. And that's how you want to remember that. It gets in there and it starts to go crazy. Pronator teres. Boom. Median nerve. Pronator teres. Here comes our pronation. All right. Median nerve. All right. After that, we start to have our wrist flexors. Flexor radialis, flexor carpi radialis, and palmaris longus. 2 big wrist flexors. Notice it doesn't do the other one. It's going to be our ulnar nerve. But it does wrist flexion, all right, the lateral 2 muscles. If you keep wrapping your head around the median nerve is controlling the lateral aspect of the forearm and hand, it's a good way to remember it. The median nerve, and that's counterintuitive because it's the median nerve, so you'd think it would be the medial aspect of the hand, but it's not. Median nerve, all right, it innervates mostly the lateral aspect of the forearm and hand. So again, flexor carpi radialis, palmaris longus, median nerve. All right. Now we start to get into those intrinsic muscles. Remember, intrinsic muscles are located in the forearm, but their tendons reach all the way to the hand, into the fingers to give us hand function. Okay, those are the extrinsic muscles. First one we know, flexor carpi, flexor digitorum superficialis. Flexor digitorum superficialis gives us flexion at the PIP joints. All right, flexion of the PIP joints. These joints right here. All right, this is flexor digitorum superficialis. It does all 4 fingers. Again, located here, operates here. Flexor digitorum superficialis. It does flexor digitorum profundus, but only for those lateral 2 digits. So flexor digitorum profundus gives us flexion at the DIP joints, all right? As distal as you can go. Those 2 DIP joints of those lateral 2 digits are the median nerve, flexor digitorum profundus, okay? So it does flexor digitorum superficialis for the PIP flexion of all fingers, and it does these lateral 2 for flexor digitorum profundus. All right, it gives us this motion. So, thinking, if I ask someone to make a fist, all right, and if they had damage to the median nerve, what you're going to find is they're going to make this motion. Okay, they're going to say, I bless you. All right, I bless you. This is the sign of benediction because they're unable to flex those DIP joints and those PIP joints. They can't do it. We're going to find out they can't do this either, but ulnar nerve's working, so ulnar nerve's flexing, but the median nerve's not. So, sign of benediction, median nerve injury. They bless you. Okay, just something to think about. Now, we also have flexor pollicis longus, which again is just going all the way to the IP joint of the thumb. Flexor pollicis longus is coming in from the median nerve. Okay? Now, what the median nerve does is it's traveled through. Down at the wrist, we have that pronator quadratus muscle, which is also median nerve. It allows us again for pronation. So pronation comes to us via the pronator teres muscle and the pronator quadratus, which are again both median nerve. All right, but the median nerve travels through the carpal canal. It travels through the carpal canal with 8 tendons. The 4 tendons that go to flexor digitorum superficialis and flexor digitorum profundus. All right, so think about it. That carpal canal is small, so that's why we get a lot of compression. And median nerve compression within the carpal canal is known as carpal tunnel syndrome. Many people struggle with carpal tunnel syndrome, and that's because of where the nerve is traveling. Where that nerve is traveling. Okay? Once the median nerve gets into the hand, it sends off what is known as the recurrent branch of the median nerve. The recurrent branch of the median nerve. All right? That sends its innervation to the thenar muscles. Remember, this is the thenar eminence. This is the hypothenar eminence. The thenar eminence, when we're talking thenar, we're thinking thumb. This is innervated by the recurrent branch of the median nerve, which just comes off the median nerve. So it's all median nerve related. Those muscles, here we go. We have, let's say, abductor pollicis brevis, for thumb abduction, flexor pollicis brevis, and opponens pollicis. Here comes that opposition, a very important motion of the thumb. It's what allows us to do what we do. Opposition gives us a lot of function. So again, those thenar muscles, which are innervated by the recurrent branch of the what nerve? Median nerve, are abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. We have one last little area of muscles that is median nerve, and that's it. It continues down and it innervates the lateral 2 lumbricals. The lateral 2 lumbricals. Remember, I said if you think about the median nerve, think about the lateral side. It tends to innervate the lateral side. So the lateral 2 lumbricals, which give us this motion, this is the lumbricals. All right, they give us that MP flexion, lumbricals. All right, those lateral 2 digits, which is your index and middle finger, innervated by the median nerve. Okay? These in-hand muscles are your intrinsic muscles of the hand. Those thenar muscles, your lumbricals, those are intrinsic muscles, meaning they are located in the hand. So if I had damage to the median nerve in the hand, all right, these motions would be impaired. Okay, these motions would be impaired. Notice I might still have this because those are extrinsic muscles operating from here, but my ability to have opposition, some thumb flexion, all right, MP flexion would be greatly impaired because those are intrinsic hand muscles, median nerve. Let's talk about things that we can see that are damaged because of the median nerve. Biggest one, carpal tunnel. We talked about, all right, it's traveling within that carpal canal, and so we start to get compression, causing numbness, tingling, and pain in the median nerve distribution. Finding sensation should be an easy thing to do if you understand what's innervated. We're thinking about the median nerve distribution as far as sensation, okay? We know we're going to have those lateral forearm muscles, all right? This is going to be median nerve. And when we come to the hand, we know the thumb, this is all going to be median nerve. And it goes the thumb, index finger, middle finger, and half of the ring finger. Again, the lateral half of the ring finger is all median nerve. Okay, again, the thumb, the thenar, the palm area, index finger, middle finger, half of the ring finger is all median nerve. So if you're doing your sensory testing, your 2-point discrimination, your monofilaments, sharp, dull, whatever it is, you need to know that is the median nerve distribution. You flip over the hand. Remember, everything back of the hand is radial except the fingertips of the 3 middle digits. That's median nerve. Okay, index finger, middle finger, and ring finger, median nerve. And again, anatomy just likes to throw us a curveball sometimes. We got it. No problem. Median nerve. So we know carpal tunnel. How do we test for carpal tunnel? One sign is known as the Tunnell's test. Tunnel means tapping. A positive test would be tapping in that nerve distribution, like in the carpal tunnel area. All right, volar aspect of the wrist, and that's causing pain, tingling, all right, sensation changes, paresthesia within the distribution of the median nerve. Okay, you can do Tinel's test in other areas, and we'll talk about that with the ulnar nerve. So Tinel's test doesn't have to be testing for carpal tunnel, but it's just one way you can test for carpal tunnel. Phelan's test, you take those wrists into full flexion. And if you understand the carpal canal, you should know this would not be a comfortable position because you're causing a lot of compression within that carpal canal. So you're going to cause pain, discomfort, numbness, tingling. Okay, and if you hold this for 60 seconds, they should have pain, numbness, and tingling. That would be a positive Phelan's test, leading you to a median nerve injury, carpal tunnel. All right, positive Phelan's test. All right, that's another way to check for median nerve issues. Other problems that you can see within the median nerve are going to be if we had a lateral epicondylitis with the radial nerve. Medial epicondylitis is when you are overworking your flexor muscles. You are overworking your flexor muscles, your wrist flexors. So that medial epicondyle area is getting inflamed. Those tendons are starting to get inflamed. They call this tennis elbow. Okay? I'm sorry, they call this golfer's elbow. And you think about how you hold that golf swing. It's more in a flexion position once you get down to the wrist, swinging this way. Where again, tennis elbow, wrist extensors are being overworked. Golfer's elbow, wrist flexors are starting to be overworked. And we just know, again, if you know your anatomy, you can figure this out. Medial epicondylitis, that median nerve travels on the medial aspect of the arm, and then once it gets to the forearm, it crosses anterior to the cubital fossa, but it starts innervating all those flexor muscles, right? You can feel those flexor muscles. So we get that medial epicondylitis. All right? So those are all things you can have. You can also have problems with trigger finger, which is a tenosynovitis of the finger flexors. So tenosynovitis, you start to have like a decompensation of those tendons. All right, and we know these tendons are really important. And trigger finger means we have decomposition, so we're starting to have trigger. It's starting to come down. So you need like a trigger finger splint, which would assist those MPs to come up into extension. Okay, usually the IP joints are free, but the MP joints are coming into extension. So again, clinical signs of a median nerve injury. We talked about the sign of benediction. They are unable to flex. This would be an issue. You are going to notice atrophy, which is muscle wasting. Muscles are deteriorating. You're going to see a flattening of the thenar eminence because these muscles are not being innervated. So there's atrophy. All right. Now, the thumb, we refer to this as apan because they don't have opposition. All right. Some of those motions, abduction, they're going to start to have apan. The thumb's just going to hang out in adduction. And this is apan, not functional at all. They're going to have a really hard time with their pinching abilities. All right. Pinch is going to start to be impaired, whether it's your pincer, because again, what do you need? Lumbricals for sure. All right. For your three-jaw chuck, again, lumbricals. You need your intrinsic muscles of the hand really to help you with those pinchers. That's why they're not so strong. It's not as strong as grip because, again, it's intrinsic muscles that are doing a lot of that leg work. All right? So those are going to be issues you see. So they're going to have a hard time picking up objects, manipulating small objects. That's going to be a challenge. And because they don't have opposition, again, further damage will be done. So those are all difficult things that we would see with the median nerve. Let's finish up talking about the ulnar nerve. Again, here they all come, traveling through the armpit or the axillary region. And like I said, median nerve and ulnar nerve travel together in that medial compartment. They don't do anything yet. They just travel together, medial compartment of the arm. Ulnar nerve travels posterior, all right, to the elbow. Posterior to that medial epicondyle, lateral epicondyle, which is why when you bang your elbow down on something, your funny bone, it's your ulnar nerve that's been irritated by that pressure. Boom, that's the ulnar nerve because that's where it's at. Ulnar nerve travels down the forearm. Now think about it. Ulnar nerve comes into the forearm and it doesn't get the same response. It's not the party started, high fives, butt slaps, hug it out, because it doesn't do much in the forearm. It only innervates 1.5 muscles, so big deal, right? It only does flexor carpi ulnaris. Flexor carpi ulnaris is innervated by the ulnar nerve, and it's in the name, so that's good. And it does one extrinsic muscle, which is flexor digitorum profundus, which gives us flexion of our DIP joints, but only of the medial 2 fingers. Okay, so that would ultimately be our ring finger and our little finger. It gives us that DIP flexion. That's ulnar nerve. So that's the only extrinsic muscle that it innervates. But that is important because the ulnar nerve gives us our power grasp, because if we don't have flexion of that ring and little finger, we will have a weaker grasp. And you think about that. You pick up an object and you can't use those two fingers. You can do it, but you're not going to have as much strength as if you could actually wrap around with all those fingers included. Okay, so that is ulnar nerve. Ulnar nerve then continues, all right? It continues into the wrist, but it continues into the wrist in the anterior compartment. So I'm going to come this way. So the median nerve traveled through the carpal canal. Ulnar nerve travels in what's known as Guillen's canal, which is on the anterior aspect of the wrist. Okay, so it doesn't go through the carpal canal, it comes through Guillen's canal. Once the ulnar nerve is in the house, now it is party on, hand slabs, butt slabs, hug it out, cue music. Ulnar nerve is here. It does like everything for the most part. The hypothenar muscles, ulnar nerve, flexor digiti minimi, right? Abductor digiti minimi, and opponens digiti minimi are all innervated by the ulnar nerve, right? It does the lumbricals, the lateral or the medial lumbricals, which is your ring and little finger. Lumbricals, which again, lumbricals give us our MP flexion. That is our ulnar nerve coming in to give us our MP flexion. All right. And then what it also innervates, we have those palmar and dorsal interossei muscles, the little muscles that give us our palmar, our finger adduction. All right. Our fingers come together for our palmar interossei, or our fingers abduct with our dorsal interossei. All right. Abduction. All right, or adduction. Those interossei muscles come and are innervated by the ulnar nerve. All right, so usually those are really important muscles to have, because when we pick up objects, we don't pick up objects with our fingers abducted like this. We open them up, and then when we pick them up, we bring them together and we pick things up. Same thing, when we open our hands, we extend, we abduct. So they go together. That's all ulnar nerve. Okay, and those are intrinsic muscles because they're located in the hand. So our hypothenar muscles for our digiti minimi, so again, that would be abductor digiti minimi, flexor digiti minimi, opponens digiti minimi, ulnar nerve, right? These two lumbricals, the ring finger and the little finger, which are actually the medial two, all right? Lumbricals, ulnar nerve, our palmar interossei, ulnar nerve, and our dorsal interossei, our ulnar nerve, okay? So we start thinking clinically about things that you can start to have problems. Well, if you think about its course, because it runs posterior to the elbow, you can have something known as cubital tunnel syndrome. And that's due to pressure being put on the elbow. So if you're sitting and you've got your arm resting for a long period of time, or if you're holding positions with extreme flexion, some people sleep like this, that can start to put strain on that ulnar nerve. You can have that as a problem. Remember when I said Tunnell's test doesn't just have to be tested as far as the carpal tunnel for the median nerve? You could do kind of a Tunnell's tapping to see if you had pain, discomfort, tingling within the ulnar nerve distribution. Okay, so those are some things you'll see. Remember what it innervates. So you're going to see atrophy in the hypothenar area. And again, you're going to have problems with opposition because it includes itself in opposition. The ulnar nerve also, what you call is the ulnar claw hand. What you start to see is this hyperextension, all right? Hyperextension of the MP joints, flexion of the IP joints. This is an ulnar claw hand that you start to see. Because again, those lumbricals in Rossi are having a hard time keeping that hand forward, keeping those finger joints forward. So it's pulling itself back into this ulnar claw hand that you'll get with ulnar nerve injury, okay? When we talk about sensory, all right, we talk about, makes sense, right? We know this is ulnar nerve, all right, little finger. Half of the ring finger is ulnar nerve, and then this area of the hand, all right, which is, again, the medial aspect of the palm is ulnar nerve, okay? That is the primary sensory distribution for the ulnar nerve, all right? The only thing that we haven't talked about that is also important to note with the ulnar nerve is the thumb has the ability to adduct and come in. Just like all fingers have abduction and adduction, the ulnar nerve is what's responsible for thumb adduction, bringing the thumb in. This is where power comes in with the ulnar nerve, because we have a test known as Froment's test. If I have a patient grab a piece of paper, okay, as such, and if I try to pull this piece of paper away, this is requiring thumb adduction. Okay, they're going to have a very difficult time doing this, or you're going to see them compensating by trying to bring in different muscles. But that would be a test for ulnar nerve injury, would be could they just hold that piece of paper and that thumb into adduction, or is that something that they struggle with? And they would struggle with that if they had a problem with their ulnar nerve. Okay, so that's something that you would see, and again, that's called Froment's sign. Okay, again, impaired power grip, because you don't have gripping of those last two digits. So you're going to have grip, but it's going to be weak. So when we think back to what we started when we talked about prehension, right? Pincers. We know that this motion and this motion, this is a lot of median nerve. So if I have somebody that's struggling with the median nerve, these are going to be motions that might be impaired, and I might want to be picking activities that work on these motions. All right. Now, if I have someone struggling with the ulnar nerve, my key or lateral pinch is going to be something that's going to be impaired. Maybe these are motions that I want to be making sure that I'm targeting to help strengthen the ulnar nerve. All right. I know power grasp is affected if I have an ulnar nerve injury. That might be something I'm working on. But that's where you need to understand what the nerves are innervating, what muscles are involved. So when we start with even sensory testing, we know the distribution area, so we can identify areas within the median nerve to make sure that we're seeing deficiencies and then being able to document progress, or locating areas that are impaired. And then we have to plan interventions. So we need to be picking activities that help strengthen the right thing. And that's where it's so important for us to understand our anatomy, because we can't make good clinical reasoning decisions, good treatment interventions, if we don't understand our anatomy and what's happening. Okay? So these are not to be feared. The brachial plexus is not to be feared. It's to be respected, understood, and just applied. And if you understand it logically, kind of how it all kind of comes together, you will remember it, and you will feel much more confident for any exam, for your MBCOT, and for clinical practice. I hope this was helpful. I really enjoyed this. Good luck.